Hello there, everyone. This is Professor White, and today we are going to be talking about the difference between SIADH and diabetes insipidus. We're going to be concept mapping these disorders together. This is how I like to do my lectures. I like to kind of break it down into those pieces, and I think it will really help you as you go through your nursing studies to do the same. We are under Next Gen guidelines, so under Next Gen, we need to recognize and analyze cues, which are assessing patterns, things you might do clinically, reviewing charts, considering patients and their values, deciding what's relevant from irrelevant information, what things in the past medical history or risk factors that may be important, and understanding the patterns that you see and if you need more data. Of course, relevant diagnostics are just those test items that will help us get to a diagnosis or an exclusion of this being the disorder that the patient is experiencing. Prioritizing hypotheses, these again are the most pressing possibilities, priorities, risks related to the solution, or risks if you don't do anything. Generating solutions and taking action, these are our goals, our expected outcomes, and our implementation. These are skills, procedures, collaborations, teaching, ethical concerns. I like medications in here, but just to help you guys study a little bit, I've separated medications out, so medications to know. So let's just jump right into it with SIADH, or Syndrome of Inappropriate Antidiuretic Hormone. As you can see here, the little picture can give you a little clue as to what's going on. I try to remember SIADH, that SI meaning soaked inside. They cannot pee, right? So basically it's an overproduction of antidiuretic hormone or release of antidiuretic hormone despite normal or low plasma osmolarity. So realistically, the body should be able to monitor this, and sometimes it doesn't, right? When we have problems with the antidiuretic hormone, so it may release too much or not stop releasing when it should. So basically too much antidiuretic hormone. The other option is an inappropriate response to antidiuretic hormone. So what do we see here? Think about what you see in the picture here. If we end up with too much fluid, that's going to dilute our sodium. We end up with dilutional hyponatremia. And what do we expect to see if somebody has low sodium? What are some things that come to mind? Headaches, muscle cramps, vomiting. The more severe the decreased sodium, the more severe the signs and symptoms. We may end up with cerebral edema, which can lead to lethargy, confusion, seizure, and coma. So as you can see, having SIADH is a terrible thing for the patient. We've learned throughout nursing that one of the best ways that we can look at fluid volume in a patient is to weigh them. So if you have all of this fluid being retained, what do you think is going to happen to their weight? Hopefully you're saying that their weight's going to increase. But what's interesting about SIADH is that they don't have peripheral edema, right? Because this is not a problem of the fluid compartments, right? It's an osmolarity issue. So there's no peripheral edema, so don't let that confuse you. So what happens when a person has too many fluids on board? Tell me about their breathing. What do you think? Think they might have some dyspnea on exertion? The clinical manifestations of hyponatremia? What about their urine output? Right? Antidiuretic hormone is against diuresis, so they are not peeing. So if we have somebody who's not urinating, the urine that they do make, what do you think about that? Do you think that it's going to have a normal specific gravity, a low specific gravity, or an increased specific gravity? You should be thinking that it's increased specific gravity, right? Because the urine is very concentrated that's coming out because the person is not able to let go of their urine. So let's look at some common causes of SIADH. One of the most common causes is cancer, especially small cell lung cancer. other issues that may cause SIADH, so we need to keep them in the background of our mind as we're assessing patients. Brain tumors, lupus, history of strokes, certain medications, including medications like Tegretol, chemotherapy agents, people who've undergone general endotracheal anesthesia, and thiazides. The older adult is more susceptible and more likely to experience SIADH. And here's the thing. SIADH can be very acute, right, with very low sodiums and very, very dangerous to the patient, or it can be chronic with a person just experiencing persistent hyponatremia that they may not even be clinically aware of, but we're finding it on labs. And if that's the case, then one of my favorite rules of nursing is if you don't have enough of something, give it. In this case, we don't have enough sodium, so we often are given sodium to these patients. All right, so relevant diagnostics. We spoke a little bit about the urine output, and I think that's important to look here. We're going to do a urine analysis, and that's going to show an increased specific gravity. Under our labs, we would want to check a BMP, basic metabolic panel, and we're especially looking at that sodium level. Remember, a sodium level that's approaching and under 120 puts the patient at increased risk for seizures. And we can also look at the antidiuretic hormone level. So let's look a little bit more about clinical manifestations of SIADH. I know I bounce around a little bit, but that's how my brain works. Thirst. I want you to remember thirst as an issue with the patient initially. But again, the more severe the hyponatremia becomes, the more severe the signs and symptoms come. All right, we're going to pop over to a hypothesis. So what are the problems, right? What are the possibilities of what could happen? For this, we're looking at the problem of hyponatremia, seizures, coma, death. And how does the nurse come into play here? Like, what's the nursing role? Well, ideally, the nurse needs to know that we need to correct the hyponatremia. Slowly is the key here. And then we need to treat the underlying cause, right? So we need to figure out, why is the person having SIADH to begin with? So that a lot of that comes up to medical personnel and working with the provider and looking at things. You might need some imaging, more testing, decide what the heck's happening. But we want to treat the underlying cause. And then some other things that we can do. Daily weights become very important for these patients. We want to know, how is their fluid status. We might have them on an increased sodium diet. A fluid restriction, usually 800 mLs to a liter daily. The person, because they're on a fluid restriction, often feels dry mouth, so we might not have to treat that. Do you guys know how to treat dry mouth? What are some nursing things that you can do? Right, mouth moisturizer, hard candies. Now here's an interesting thing that we can do for somebody with SIADH. Keep the head of the bed at 10 degrees or less. And you may say, well, Mrs. White, why would we keep the head of the bed lower? Well, assuming that your patient isn't in respiratory distress, this is a perfectly great thing to do for a patient. This is because it helps decrease antidiuretic hormone release by keeping the left atrial pressure regulated, right? Keeps it lower. So one of the ways that we know that we need antidiuretic hormone is the body monitoring the left atria. So that's why keeping that head of bed just lower helps that out. We want to avoid meds that increase antidiuretic hormone. Of course, safety, safety, safety. Can I say it one more time? Safety. Anytime we have a patient who has hyponatremia, you should immediately begin to think about the seizure risk, the fall risk, and start implementing those precautions immediately. Seizure precautions, fall precautions. What do those look like? If you're not sure, I want you to look in Nursing Fundamentals books and see, how do we treat people who are at risk for seizures? How do we treat people who are at risk for falls? Is this the person you put in the last bed at the end of a very deserted hallway? Seems not. All right, and why do we correct hyponatremia slowly? The reason we do that is because we don't want big fluid shifts in the brain, because that causes cerebral edema and that can cause more problems, right? We don't want to cause more harm than what we're trying to correct here. So we correct the hyponatremia slowly. All right, so what are some of the medications that you need to know? Democycline, so that's spelled Democycline. What that does is it blocks antidiuretic hormone. So it increases the urine output by blocking antidiuretic hormone. Some of the other medications might be good old-fashioned sodium chloride, right? I'm used to giving people sodium chloride 1 gram 3 times a day. It's a salt tablet. We might give a patient diuretics, especially loop diuretics, furosemide. Do you guys know what to look for when somebody has furosemide? What do you think? Furosemide takes potassium with it, so the person might become hypokalemic. So we have to be very careful of that. We might need to give the person hypertonic saline, 3% saline. Problem with giving somebody hypertonic saline is it's very dangerous. It can cause massive shifts in fluid. It could cause cerebral edema. It needs to be given in a critical care environment. So take a minute and review hypertonic saline. And then we do have some vasopressor receptor agonists. These are things like conivaptan, which is given IV, or tolvaptan, which is the oral form. Problems with these meds is that they tend to affect liver function. All right, so I just want to make sure I'm not missing anything. And I don't think I am. So again, this is also to be reviewed in your textbook about syndrome of inappropriate antidiuretic hormone. So now let's take a gander down to the next thing, which is diabetes insipidus, right? So one was too much antidiuretic hormone, and on this case, diabetes insipidus, it is too little. All right, so we have the opposite problem from what we saw before. Before we had too little sodium, now we have too much. All right, so diabetes insipidus is a deficiency of the production or secretion of antidiuretic hormone or decreased renal response to antidiuretic hormone. So basically they end up with a lot of fluid and electrolyte imbalances. They can't stop peeing. They become dry inside. So that's where we have to spend our time. Before they were hyponatremic, now they're going to be hypernatremic. All right, so somebody who's dehydrated, because this is really what this looks like, clinical manifestations, polydipsia, right? The person's thirsty. One of the things that I teach people is that when somebody has too much sodium in their blood, one of the first clinical manifestations we get is that they are thirsty, right? Polyuria, these people are peeing out more than they're taking in. And that gives them that risk for hypovolemia. And hypovolemia, uncorrected, can and will lead to shock. Their urine output can be greater than 200 mLs an hour. So as we're looking at patients who might be at risk of diabetes insipidus, let's look at some common factors. Recent head injury would put them at risk. Recent head surgery. Brain tumors. Central nervous system infections like meningitis. Certain medications like lithium. People with renal damage. And very, very rarely there is a psychiatric condition But again, we're not going to spend time on that. First of all, I don't teach psychiatric care. And second, it's such a rare cause of this that it's not something that we're going to spend a lot of time on. All right, so centralized diabetes insipidus is usually very acute. Excess fluid loss. This is why we look for it after all of those surgeries that we do on the hypothalamus or anything in the brain, because that damage can cause us to come on pretty darn quickly. So, diagnostics, what do you think? Hypernatremia. We check that BMP and we are going to see elevating sodiums. Low urine specific gravity. These people cannot concentrate their urine. One of the best tests we have for this is the water deprivation test. Basically, in order to do this test, we check a urine sample every hour, blood samples every 2, and we check their serum sodium before and after. But before and after what? Basically, no water for 8 to 12 hours, and then we give them DDVAP, which is antidiuretic hormone, desmopressin, and we see how they do, right? We check their urine osmolality, and we check their blood samples to see what's going on. We have to monitor the patient's weight during this. We need to not continue the test if the patient's weight decreases by 2 kilograms. And the other thing to know about the water deprivation test is that they need to have a normal serum sodium before they initiate the test. All right, so let's go on over here to hypothesis. So 2 main issues that we're going to run across. One of them, of course, is hypernatremia, and that can become life-threatening. And the other is hypovolemia, which can lead to shock. So now we have to come on over and take action, generate solutions. What do we want? We want to see the patient be euvolemic and have a normal serum sodium. So the treatment really is, once again, daily weights, low sodium diet, right? Not to exceed 3 grams of sodium in a day, right? These people have high blood serum sodium, so we'd want to not give them any extra. No chips for these guys. They may need fluid and hormone therapy and oral or IV fluid replacement. That fluid replacement is usually D5W for acute diabetes insipidus. And D stands for dextrose, 5% dextrose in water. So anytime we start to give people sugar, we have to then monitor their sugars. We give DDAVP, or antidiuretic hormone replacement. We can give it oral, IV, subcutaneous. We can give it nasally. Thiazide diuretics, and these are medications like hydrochlorothiazide, chlorothiazide. I said that completely wrong. Chlorothiazide. And we usually use that for more chronic cases and in conjunction with a low sodium diet. And one of the interesting meds that we can use is indomethacin, which is an NSAID, because what that does is it increases the renal response to antidiuretic hormone. Does this make sense that indomethacin might help for peripheral diabetes insipidus, one that is caused by their kidney function, but it would not help central diabetes insipidus, and vice versa? Just giving the replacement doesn't always help the one that's caused by the renal impairment. But anyways, we're going to end here. This has been a comparison of SIADH and diabetes insipidus. Hopefully now you can tell me the differences when you come to class, and that's that. All right, guys, thank you.